Welcome back to the Rook's Health Podcast. This has been a long while since I think I recorded another podcast, but I am very lucky to have a wonderful guest today talking about a topic that I think my own area of physiotherapy that I quite find to be one. I wouldn't say I'm a specialist in the area, but it's one I have a lot of interest in, the neurological field. And today I have a guest with me that I would say has a vast amount of knowledge in both the clinical practice as well as research in this field. But I will let her introduce herself so that before we carry on talking, and I'll let you introduce yourself.
Great. Thank you very much for having me on. It's a pleasure. So, yeah, I'm Gita Ramdharry. My current role is I'm a consultant allied health professional in the field of neuromuscular diseases. And it's a bit of a split role. So I mainly do see patients and sort of consultant level practice. I have my own follow-up clinics, but I also for some years have conducted research into supportive care and rehabilitation for people with particularly neuromuscular conditions, but I've done some early work in MS, and I'm also supervising studies in other conditions as well.
Yeah, I think you've already mentioned quite a few things that I have interest in and patients I see. I'll tell the people roughly how I think we met and how we've come across to having you on my podcast. I think we met over Twitter. And physio Twitter, I always say, is a wonderful place to meet interesting people and meet different people from different backgrounds. I think came on my radar, or I came on your radar about last year towards around when Bain movements were at its peak, and there were a lot of different talks about the racial inequalities and physiotherapy and healthcare and things like that. That was initially how we met, and then fast forward, I think a year or two later, I think it's been 2 years now since the initial, and now we're having you on my podcast because I always knew that I think we had some quite good knowledge in neuro. That's a field that I quite had interesting. Did I miss the event, or does that sound about right to you too?
No, that sounds about right. Yes, I think as you say, physio Twitter sort of came alive for many of us, particularly from that movement. Absolutely.
Yeah. So I brought you on today to talk about the first topic which we have for the day is particularly is progressive neurological disorders or conditions, as you may call them. I think me personally, I work as a community physiotherapist, and I see both neurological patients, musculoskeletal patients, and a bit of respiratory patients. But I do have a more keen interest in the neurological side due to I had a very good experience in neuro and the amount of treatment you can provide to people. And one key thing, I think it was a good place to start off, is one key word you hear in physio a lot of time is rehab. It's the rehab. Okay, we're going to do some rehab. We're going to progress you. We're going to rehab. These are almost the buzzwords, key words when you think of physio immediately. However, I know we've had a chat about this a little before. For neurological diseases that are progressive, that word itself, rehab particularly, is not always, I'd say, a clear picture, or is not probably the best word you can use when you are treating someone who has progressive disease. What word would you use? I'll let you start off with.
Yeah, I think that's a great question, actually, and a great. I think the definition of rehab, and when we think about rehabilitating people, we always think about improving. So, for example, in the neurological field, we very much people after having had a stroke, for example, it's that trajectory of improvement you associate with rehabilitation and rehabilitation units. I think one of the terms that I've used more is physical management. Because I think that then can apply across the board no matter what the trajectory is. However, what I would say is that with neurological conditions that are progressive, you have some which are very fast progressing and you have some which are much more slowly progressive. And it can be a little bit different there. So I tend to see mainly people with quite slowly progressive conditions in my practice. So I see people with adult onset muscular dystrophies or polyneuropathies, that genetic ones that progress very slowly over time. And sometimes you are looking to improve. So if somebody's not had any input for a long time, they've become very deconditioned. Or they're having some problems with pain, for example, that might be musculoskeletal. Actually, you can be putting in place interventions that will look to improve where they are from that baseline when you see them. I think with some of the faster progressing conditions, such as motor neuron disease, and some of the rare Parkinsonisms, for example, it is more about managing the person and using physical techniques or physical support or problem solving. So that's where I think physical management at least covers both of those.
Yeah, I think you said it quite well in terms of improvement as well as management. They kind of coincide with each other. I think from my perspective, I'd give the example of gave quite a good one as well. You're going to maybe someone who has had no physiotherapy or no therapeutic input at all, and they've been dealing with Parkinson's, for example, which is one I think a lot of people are familiar with. And then we come in there and we just improve their quality of life. We're not necessarily improving the disease itself or the condition of Parkinson's, but we're improving the quality of life. But we're managing the Parkinson's as a disease and the symptoms that they present with. Would you say that's a fair way to look at it?
Definitely. And so, I think years ago, we didn't think we could necessarily impact the trajectory that much.
Yeah.
However, this is where me as a researcher comes in, which is quite interesting because if I'm doing reviews of articles looking at Cochrane reviews or I've contributed to a Cochrane review that was published last year, and I'm doing a review at the moment about exercise in myositis, which is an inflammatory muscle disease. Well, there's different types, but it's an inflammatory condition. And I think the same is true in Parkinson's as well, that there may be some evidence that actually there could be some physiological effects that actually could impact on the progression rates. It's not definitive. I don't think it's necessarily definitive in many of the conditions that I see, but there's certainly interesting work coming through. And an example, so as I say, we see a lot of people here with muscular dystrophy, and there's one which is the slower progressing type. It's one of the more common muscular dystrophies called facioscapulohumeral muscular dystrophy, FSH. Okay. And some colleagues did a study where they were examining the change in the muscles over time using MRI. What we see when people have a muscular dystrophy or a muscle disease is that on MRI, you can quantify the change in the muscle because a muscle that's been damaged due to the dystrophy will be replaced by fat. So there's very clever ways that my colleagues can basically count, and estimate the percentage of fatty infiltration. And there was a small study, it needs scaling up, but there was quite an interesting finding where there seemed to be a difference in the rate of change of this fatty infiltration in interventions that involved exercise or increasing physical activity compared to people who didn't. And there's been a similar thing observed, similar pattern observed in terms of strength in people with inherited peripheral neuropathy in young people. And also I've just been reading about, just this morning I was reading one of these myositis papers that showed there was a reduction in inflammation. So actually there's, I think as physiotherapists, we think about disuse and decondition, how we can reverse that and maximize people's function, optimizing what they have. But there might be some interesting things, and certainly in the diabetes world. So where we see people with diabetic peripheral neuropathy, they have quite clever ways of being able to count the number of motor units in the dermal nerve receptors, because it tends to be the small fibers that are more affected with diabetic neuropathies, and they can count them. And they found that with diet and lifestyle, which includes exercise and physical activity, you get a proliferation of these. So it could be affecting tissue level change, which actually could be affecting the condition as well as all of the metabolic improvements that can happen with people who are diabetic or pre-diabetic. So I think there is the optimizing function, but we might be having some other effects. We might be potentially slowing down some of the progression, but I think that needs to be expanded and looked at, a bit more before we can definitively say that. But it's quite encouraging, it's quite exciting, actually.
Just you saying that is very interesting. And I think I've heard this. This was the word I'm looking for. This line of thinking and this line of science before that. Normally I think when you think physio, you think we're only impacting, as you said, the functionality, their quality of life, what they can do on a functional basis. Can they still be able to do this activity? Are they still able to do the activities of daily living? Are they still able to do this? What you're saying now is that, the evidence potentially, obviously, it's not exactly where you would want it to be in terms of evidence, where you can be making definitive statements saying we are definitely doing X, Y, and Z. But you're saying that is possibly something maybe happening that, beyond just keeping functional, we may actually be impacting the underlying disease in itself.
Yeah.
But you'd like to see, more evidence done. I think that's always the interesting thing with research, is that more research can always be done to make something more.
Yeah.
Rarely, I'd say, let me just say never, rarely a bad thing to do research something in more depth and get more papers and more studies out there regarding.
Yeah, well, you need numbers, you need sort of to be robust, which is why things like systematic reviews are helpful for bringing data together. But one of the challenges that we face in the sort of research that we do into the sort of interventions that we do is that there tends to be challenges with that in terms of outcome measures that are used, and perhaps there are whole swathes of outcome measures that can be used. That means it can be quite tricky to pull some of this together. But there are opportunities to do that, and we have been able to do that with things like exercise testing. So looking at oxygen uptake, VO2 max for aerobic training actually does show there's some moderate evidence for effect in muscle disease, for example. That was that was from a Cochrane review that was a couple of years ago, and I actually reviewed that before it was published. So it is gathering, and I led an exercise trial a few years ago in aerobic exercise training in people with a myositis and a peripheral neuropathy, and with VO2 being our primary outcome, we got a 14% improvement in one group and an 11% improvement in the other, and there were big effect sizes. So we can be impacting things. What I think we need is some harmonization and some recommendations. There are things called core outcome sets that groups look at. I was involved with a group that looked at this for physical activity interventions for rare neuro conditions. So that then there's some consensus, or there's some common measures used across the board. So then some of this data can be pulled, and that then gives us a bigger weight of evidence.
Yeah, I think you said it correctly. I was reading recently, off topic, where we'll come back to what we're talking about. I was reading for a journal club for our team was about orthostatic hypotension, and one of the critiques, and I think it was by Dr. Angie Logan as well. I think you're familiar with her well. Was one of the and her colleagues as well, was that there are so many different studies all investigating similar things, but some of them were not using the same outcome measures. So you're all getting here and here results from here and here, which clinically and at the end of the day, I still think it was very clinically relevant, but statistically is a different story. When it's one of the clinical considerations you have to think about when you're looking at studies. But I also wanted to specifically talk about, you've mentioned a few of the progressive conditions for people listening, who I think the most common ones, and if you can add some more for me, if I missed out some of the more progressive ones. I know Parkinson's is dementia is a progressive condition, motor neurons disease, multiple sclerosis. You mentioned polyneuropathies, which we might touch on later. You mentioned some other ones, some more other progressive diseases.
Yeah. So, I think the most common ones are Parkinson's disease, MS, and as you say, dementias. But dementias, there's lots of different types of dementias as well within that. So, most of my practice is people with nerve and muscle conditions. So, there's an umbrella name for inherited peripheral neuropathies, which is Charcot Marie tooth disease. So some of the listeners might have heard of that. Yeah. Sometimes people with Charcot Marie tooth disease present actually in orthopedic clinics because they get a lot of problems with foot deformity and often need foot surgery. So I've actually given talks to orthopedic colleagues before, about CMT. Muscular dystrophy, I mentioned inflammatory muscle diseases, but also there are some rare types of Parkinsonisms, so multi-systems atrophy, progressive supranuclear palsy. These are all quite rare. Yeah. Huntington's disease is another rare degenerative condition. Ataxia, so where the cerebellum is affected. There's actually, in some of the genetic conditions that we see here, there's some crossover. So there are some conditions of people I see where they have they might have a cerebellar ataxia and a neuropathy. That's they're rare conditions, but they crop up, and there's new genes being discovered all the time. And another condition I see quite a lot of is one called hereditary spastic paraparisis. So when you get like a high muscle tone in the legs and a diplegic gait. And some people with, not everybody, but some people with that condition also have a neuropathy. Okay. So there's sort of crossovers, there's phenotypic crossovers with some of these rare genes that are coming through. But the rate that they're now discovering the genes, Faraka, it's just huge. It's so fast now. Years ago I was giving talks on CMT not that long ago saying, there's 80 known genes for CMT. Now there's 120. In about 2 years, that's expanded massively. So
the science evolves.
Yeah, I think with sort of technologies like that come through the 100,000 Genome Project and full exome sequencing and full genome sequencing, and my colleagues here do a lot of work in that area. It's a really evolving field. And the other thing that's quite exciting for these hereditary conditions is that we now have gene therapies. So for Huntington's disease, for example, and there's a condition called spinal muscular atrophy that where there's now gene editing therapies for that as well. So so it's going to become, I think, a bit of a new dawn for us in terms of we will be. I think my gut feel is that as these therapies come on board, that there's the potential for perhaps stopping progression with these, or certainly slowing progression with these medical therapies. But I think we still have a really key role in optimizing. And I also wonder whether or not there's an opportunity for inflating these effect sizes that are seen with the drug interventions. If the drug, for example, is focused on increasing muscle mass, for example, then having the physiotherapy and rehabilitation alongside that is going to be crucial. So I think we're entering a new dawn and a new phase, I think, in progressive conditions. So
I think
we'll see where we go with it.
I think, as you said, as we continue to evolve, the same evidence that we had 5 years, 10 years ago is more very likely to be a good starting point for what we do in it, clinically, or what is actually done to the patients. It will still evolve, and you do another study now and you might find different results, or you might find that you can do a systematic review of recent studies only, and you might find that the patterns that they're showing are a bit different from the patterns of all the systematic reviews. What do you think about that?
I don't think that's necessarily just for this experience I've got doing this review of myositis at the moment. We basically reran a search of the one that we did for a Cochrane review that we published, that we actually ran the search in 2018, and there's been 11 new papers since then, so it's been a bit exponential actually. But a common pattern of findings. But I think what's been a little different is actually different modalities of people. This is about exercise, so it's actually looking at different ways of getting that exercise effect. So with a couple of them, it's using things like blood flow restriction for muscle contraction. So or HIIT training, is that another more efficient way? So it's looking at how we delivered it most efficiently or effectively. In fact, the paper I'm reading for at the moment is really interesting because it's a robotics one. It's one of these cybernetic, it's a Japanese robot. So it allowed people to practice walking, but actually was driven from the motor unit firing of the person with the condition. So quite fascinating. I'm still trying to get my head around how that works. But so actually is it other adjuncts that allow people then to be able to practice and get those benefits.
You're saying that it's not necessarily that, but I know in some cases there will be some cases, as you said, you're currently doing that study where it's not necessarily showing completely different results between the past and the present. It may just be adding to what's already out there, particularly, or slight changes in the way things are being tested, but still giving similar results or enhanced results, as you said. Trying out different exercises.
Yeah,
therapies.
There is that, but I think one thing that's been really common, and one thing that has really struck me as I've been doing this review recently, and I'm actually doing this review with a person living with myositis, so we're co-writing this paper together. We had a conversation about what we were finding, and this is also something I found after the exercise trials that we've done, is that while somebody's engaged in a research trial, they're motivated, they're getting lots of attention, they're coming in to see us, we're taking lots of measurements, it's all quite novel, they're getting lots of support from a research physio or a trainer or whoever is helping them with the intervention. They might be getting some digital support. And then when you then check in with that person, maybe 3, 6, 12 months down the line, the percentage of them that are still exercising to that level drops off massively.
Okay.
And so, I've talked to a few colleagues about this who've run this sort of work before, and that we started a collaboration called PARC, which is called Physical Activity in Rare Conditions, like a collaboration that we did with patient representatives and charities as well. And we realised that actually the common ingredient that really motivated people to participate and to maintain their level of engagement with the training protocols was the support. And so actually, should we be looking at maybe the next step isn't a robot or something, really novel. Actually, maybe it's behavior change. Maybe it's how do we support people to make habits of that level of physical activity, building it into their lifestyles.
Yeah. I mean, we know this is physiotherapists also. That's an interesting point. We know this is, therapists, so people are mostly medical, that, if you were to do, if you started a whole exercise program or you started doing something for 3 months, you could see changes within that 3 months. But if you don't keep it consistently and you left it for 2 years later, those 3 months effects, they will very likely
drop off.
Yeah, they would significantly drop off. I know this from even this, we're talking real world experience. If I go to the gym and now I'm fasting during Ramadan, by the time I go back and start trying to do what I was doing beforehand, it's going to be very difficult. So it's going to be a natural drop off. And it's a question of, are we supporting people enough in terms of that long-term effect?
Yeah,
because you were quite in depth with research per se. So in terms of you mentioned myositis, but actually I wanted to ask you, can you define what is myositis for people who are listening and who are not familiar with that condition?
So it's a group of conditions actually. So there are inflammatory myopathies, so where there's inflammation within the muscle tissue. So there's condition called dermatomyositis, which affects the muscle, but also can affect the skin as well, and that's often a key feature. There's one called polymyositis, necrotizing myositis. There's different ones that can rarer types. There's one called anti-SRP myositis, and there's one that I see a lot of people with called inclusion body myositis, certainly spontaneous inclusion body myositis. So these conditions are quite rare and often need a biopsy to diagnose them. But certainly with inclusion body myositis, it tends to come on in older people, whereas certainly dermatomyositis can often come in, there's a juvenile form, and it comes on earlier in life. And actually there's a theory with inclusion body myositis that it's actually degenerative, a little bit. I've heard it described as sort of Alzheimer's of the muscles. So you get sort of protein changes and accumulation. So it has been described that way. So it's not necessarily inflammatory, but it's a bit more degenerative. But there's a very distinct pattern of weakness. Often it's proximal weakness, particularly of the lower limbs, quadriceps, for example. So these people often have problems getting out of chairs. With inclusion body myositis, there are problems with long finger flexors, so grip becomes really affected. They get foot drop. So swallowing problems as well. The vulvar muscles can be affected. So it's an umbrella term, myositis, but it's a group of conditions. But people with those conditions do crop up.
The thing is, I was going to say, even though it is a rare condition, and I think I may have come across one or two, or maybe only one person, but there are a lot of rare conditions, as you will say, and if people who work with neurological patients or work in, who come in contact with neurological patients, that, you see someone and say you'll hear a disease name and you come and I'm not familiar with it. You have to go and do some research on it. But these rare conditions, they're even though they are quote unquote rare, if you add them all up together, all the rare conditions, they will make a quite significant chunk of the population of people.
Absolutely.
I remember clearly when I
Yes.
was in I was working with a neuro team, and almost every week or every couple of weeks, I would see a new pathology that wasn't the textbook university taught, which, as you said, even from like Parkinson's, has different variations of it in so much that you see rare ones within that, and you have to do more to educate yourself. I mean, from your perspective, you work in the research field, so you are, this is your bread and butter per se. What can we do, from a therapeutic standpoint, a therapy standpoint, to keep ourselves up to date, or is there anything that we're missing, particularly when we're managing these conditions?
Yeah, I think it is tough, and mind you, I think it's a bit easier now with Dr. Google and that's the thing, way back when. But because I work at the National Hospital for Neurology and Neurosurgery, Queen Square, so if a lot of rare conditions come our way. And when I first worked here, I first came here in 2001 in the outpatient department, and I would have to grab a book off the shelf, clinical neurology book, go, what on earth is this, and flick through it. I think now that there's more readily available information, so we are trying to get resources out there. So certainly I a few years ago, with some colleagues working in neuromuscular diseases, we've done an online module that is available through Muscular Dystrophy UK. And so we did an adult module. I know that my paediatric colleagues did a paediatric module. And a lot of the charities will link in with people like us to get information. So actually find the charities as well and contact them, because often they'll have pages for professionals where they can signpost to different resources. But also, you can have a quick look at some of in terms of textbooks and things like that. We're rewriting, updating the Physical Management and Neurological Diseases book that I'm editor for with Sheila Lennon and Geert Verheyden. And so amongst that, there's a chapter on hereditary neurological diseases by two colleagues who specialise in Huntington's and ataxias and HSP. And then part of a group, we're writing one on muscle diseases, and then myself and two colleagues here are writing one on nerve diseases. So we will mention some of the conditions in there. So that's coming out soon. There is the 2018 version is around and about. So I think that's helpful at student level or newly qualified level. I think when people are a bit more experienced, I think if I need to find out quickly about a condition, for example, and what work has been done in physiotherapy or exercise, or can I exercise this person with this condition, or actually is it going to be detrimental? I will go onto a search engine, whether it's Google Scholar or PubMed, and I will put something like myotonic dystrophy physiotherapy, and then I might put review, because then if there's been any review articles that can sum some of the evidence, or somebody's written a narrative piece on it, an up-to-date one, and that can be very helpful to get up to speed very quickly. That's kind of a bit of a on-the-fly top tip. But there are these reviews. It's a bit like the myositis paper I'm doing. It's not a systematic review. It's more of an educational review. Okay. So they are around, and it might be that it's not physiotherapy. It might be that you put exercise and myotonic dystrophy and review. Yeah.
I think that's the thing I always think about in terms of finding out new things. And this is not to say PhysioTwitter. PhysioTwitter is very much dominated by MSK particularly, and and I at one point I used to think to myself, am I just not following the right people? Am I not in the right stratosphere? But it is primarily heavily to MSK. You will find a lot of debates about MSK pathologies, MSK this, MSK that, and I do work with MSK, so it is relevant to me. But I also do work with neurological and respiratory patients. I don't see enough of it, which I think I've used that as a tool to learn a lot of things. But even sometimes my learning plateaus. So you mentioning a few of these things like this now, I will be looking out for them to see what they can do for my practice. Yeah. And I think, which we might touch on the next episode, is that allowing, which I think is more relevant for healthcare professionals, is that allowing the research and the statistical and the clinical research done to actually impact your practice. And I'll come back to that one again on orthostatic hypertension. My whole team of the community therapists, we left when doing the journal review, and then I had to present it a little bit again, thinking that I can actually take what I've just learned there and put it in the next patient I see with postural drop or orthostatic hypertension. Because I think, as you may know, some studies have their relevance to certain individuals, certain communities. And correct me if I'm wrong, where, some research is for research purposes to do further studies, whereas I think some are actually very helpful for some everyday physiotherapists. But can you correct me if I'm wrong, or is that fair to say on research? Because you are the researcher between the two of us.
Yeah, well, I think when it comes to looking at research, and those of us who are doing research, there's a bit of a pipeline, and you might recall this when you've looked at it in the past. But you have your preclinical research that our colleagues will be doing in the labs. They'll be looking at mouse models or tissue models or whatever, and then there's preclinical studies, and then when we're actually looking at, I think we tend to sit in studies that are going to look at the experience that patients are having now within services. What can we deliver within current services? How can we improve functional quality of life for somebody's, experience within their environment? So we're definitely at that end of the spectrum. We tend to be. I do know some physios have gone off and done mouse work, etc., and pain and that kind of thing. But on the whole, my PhD work was in the biomechanics lab. So that and actually I'm writing a proposal at the moment to go back to the lab to look at some mechanistic work, but then with a view to then translating it into then how, when we understand the mechanisms of what somebody is struggling with, for example, let's say balance, look at the balance physiology, what are the problems people are experiencing, then how can we tailor interventions to address those problems? How can we co-design those with people, then test if they're feasible, and then go to full trial? That's kind of the continuum. But it's always about patient benefit for me and many of us. Ultimately that's what we're trying to do if we can get some improvement, and this is actually what's really important that a lot of researchers do now, and certainly I do, is you do that in partnership with people living with the conditions, because they can tell you what's important in terms of what they want to change with a particular intervention. We did that with the physical activity and rare conditions work. We partnered with people living with conditions, said, well, okay, so we're going to propose this core outcome set, but we want to make sure that we're collecting outcomes that show meaningful change for you. So what's important to you to change? And they were saying things like physical well-being, psychological well-being, being able to do activities, so participation and that sort of thing. So that partnership's really important.
Okay. I think you said that the right way in terms of, it's all about the patient at the end of the day. And that's an interesting way. I didn't know that many studies did that, where they include the, people who are going through that condition involved in the research, in the back end parts per se, as opposed to just the, as on the participants of the study, which I think is an interesting concept, and I think it's one that would be greatly beneficial if you can get people while you're doing it, just to make sure that whatever you're doing in terms of research, and actually before you start collecting all this data or using all these outcome measures and modalities, actually relevant to the people you're aiming it at. I think one thing I wanted to we can use this to cap off what I think, because this has been I like this because this has been very, very, very relevant, particularly for clinicians per se. When we talk about physiotherapy, therapy, occupational therapy, any form of interventions for patients, we have the medical management side, which is pharmaceuticals, that I think, from my perspective, work hand in hand with therapies as we do physical activity, exercise. What can we expect from a therapeutic standpoint in terms of the outcomes of a patient? If I'm treating, I'll drop it down. If I'm treating a patient with a progressive condition and I'm doing exercise and I'm, truly trying to maximize their function, is there a point where, where is that plateau point? Where is that point where I say, that is clinically justifiable for me to say, okay, it's time to pull out and say, I think we've reached a good step for now, and it's time to come out? Because it's really difficult with a progressive disease, because it's not like ankle fracture, for example, or ankle sprain. When the ankle sprain is back, when they're back running, you can really easily say, okay, I think it's time for me to let it go now. I think we've achieved their goal. But when you're setting goals for people with progressive diseases, And it's really tough. And I can only empathize with people. I don't have a progressive disease to say, they want to get back to where they were before. But we know as clinicians that is unlikely, to say the least, if it's going to keep progressing worse. What are your thoughts on that as to how can we better from our standpoint? I think the next podcast, we might take it from the patient standpoint. What can we do with regards to that? Is there anything we're missing or we need to look at in terms of when we're managing these progressive diseases in terms?
So I think the first thing I would ask somebody is, what do you understand about your condition? So what's their knowledge on their condition and what the trajectory is and what they might be, experiencing down the line. And then getting a sense of what they already do. But I think the idea of goals is an interesting one, because again, we always think about goals having a very much a sort of a rehabilitative type improvement focus. And for somebody, with some of my patients, that's appropriate. So I might have somebody who's, had a fall and they've got a bit deconditioned because of that. And then, so actually you are trying to improve them to get them back to where they were before the fall. And so that would be the goal. With some people, it might be about maintaining function. So as I was saying earlier, if you think about sort of trying to think about that trajectory. I have to say, though, with some of the people I see, it's actually more about forming habits, because we know from the data in many conditions that actually the people who tend to be more physically active, for example, often do a lot better. It could be a little bit chicken and egg, and I think that probably needs exploring a bit more. So actually, some of the goals I might set with somebody is actually not about whether or not they can walk this fast for over 10 meters, but it's actually them being able to engage in physical activity for, half an hour, 3 days a week. That might be the goal. It actually might be about that behaviour change that's going to be beneficial for them. So I think I think you have to know again what's important to the person. Yeah. I was talking to somebody the other day who has a progressive condition, who had it later in life, and he said something really, really interesting. It floored me, actually. And he said, when I was used to be a bodybuilder, I was chasing something. I was chasing, that next goal, that next target, next sort of thing he was working hard for. Yeah. He said, now with my condition, there's something chasing me. So with some people, and I've had a few people say this to me, actually, it's that fear, if I stop, will it overwhelm me? So actually supporting people to be able to engage, but and maintain for as long as possible. It is really important. So for example, if it was somebody who had a fall and then I'm helping them get back to where they were, that would be the goal. And then that's when you would know that somebody had plateaued or they're back to their pre-morbid level. So that's when you go, great, you're doing great, carry on, here's your maintenance plan or whatever. Whereas with the other people, it's about, well, we know we have a good inkling that certainly exercise and physical activity could be very helpful for you. So the goal would be about engagement. But don't forget, we don't just do those things in neurology. I've got my little foot here with them. We do a lot of work with orthotics, for example. So actually you can change somebody's function very quickly. If somebody's got foot drop, put one of these on and time they're walking, and that could be your goal. It could be around them not falling every day. It could be that they only fall once a week. So I think it's got to be very, very specific. But I think having that discussion with that person right at the outset about what's important to them to achieve. What would you like to get out of this session? What would you like to get out of these sessions that we're going to have? Actually should be how you set your goals.
Absolutely. I think that's quite helpful, actually. I think even I've been doing some of those things in terms of from the outset, as well as you said, always try and set it within the first 2 sessions. That's what I always tell myself, setting goals and making sure you're not imposing what you think they want, particularly on them, but it's actually what they want. And it's just management of that expectation, particularly, which I think will be a very nice segue into the next part of this podcast. But we will close this one here for now. I think that was very interesting. I think you've given some very good, that'll be helpful for any medical professional, to be honest. And I'm not just saying specifically physios. We are biased, definitely, because, well, we are physiotherapists by nature. But I think it's relevant to all others as well. Before I close out this session now, is there anything you want to add, or are you happy we should leave it there for now?
One thing I might just quickly add, actually, so the sort of communication I was describing there is very much come from some training I've had in self-management intervention called Bridges. And so the Bridges is a social enterprise led by Professor Fiona Jones from St George's University, London. And we worked with, so she's done a lot of that work for supporting people with self-management interventions after stroke. Now, self-management isn't just giving somebody a sheet of physio tools, exercises, and leaving them to it. This is about supporting people to make decisions, engage with things, try things out, reflect, set goals, etc. And actually, in that training, it does teach you certain ways to ask a question, to encourage somebody to explore. And we've worked with her and her team, and we've developed something called neuromuscular bridges. So we now have a bespoke bridges for our patients with nerve and muscle conditions in particular, which is there's a PhD student working with me at the moment who's just evaluating this at the moment. And so I think that communication, whether it's through that paradigm or it's through things like motivational interviewing, but actually I think that's more important than ever in long-term conditions, that we are using our communication not to just tell somebody what we're going to do, but to pull that out and give people that choice. It might be that person is not interested at all in being physically active. Or actually, the thing that I find a lot is that a lot of people hate the word exercise. Yeah. They might have had some of the patients I see with Charcot Marie tooth disease, where it comes on in school age, they had a horrible experience of school sports, always picked last, couldn't run, or were very slow and would fall a lot. So you mentioned exercise, and some people just will disengage straight away. So actually it's thinking about, well, what are other ways? So getting at things like movement, how do you bring movement into your day? So it's rephrasing, but until you have that sort of discussion, that exchange with people, knowing where you can get in, where are the points that you can get in, and they can make those changes, and that's driven from them. So there's more ownership and hopefully more motivation.
I think absolutely. I think that one you just said was one I've seen in firsthand, where as soon as you mentioned the word exercise, you could you said a lot of different things and they will be very engaged. But as soon as you said, I want to give you some exercises now, and you can tell you've already lost the page. So it's wording them in terms of words we use, which is very important. No, I think that was a good one to add at the end of there. Much appreciated, Gita. And we will see you in the next episode of the podcast.